This is a video created for ECMO novices where we will discuss some common questions that come up during VV ECMO management surrounding gas exchange, the membrane lung, and the ventilator. Let's outline some questions that we are going to answer. How do I treat hypercarbia? What is my oxygen saturation goal? How do I troubleshoot hypoxemia? When is pathologic recirculation occurring? How do I detect circuit gas exchange failure? And how should I manage the ventilator during VV ECMO? ECMO knobology is pretty simple. You get to adjust three things. Number one, the speed of a centrifugal pump in revolutions per minute, which determines the blood flow in liters per minute. Number two, the flow rate of the sweep gas in liters per minute. And number three, the FiO2 of the sweep gas. In general, the blood flow rate and the FiO2 affect oxygenation, and the sweep gas flow rate affects CO2 removal. Let's take a closer look at the membrane lung. This is the cross-sectional illustration of the membrane lung, also called the oxygenator, showing the course of blood flow with the inlet on the right and the outlet on the left. This is an illustration showing the course of sweep gas flow with the inlet at the top and exhaust at the bottom. Sweep gas travels through the lumens of microtubules with a semi-permeable membrane, which is analogous to the native lung's alveolus. This is an image of the microtubules inside the membrane lung with a close-up figure on the right. Each microtubule is bathed in blood, analogous to the capillaries surrounding alveoli in the native lung. When sweep gas runs through the microtubules, blood is able to extract oxygen and CO2 is removed. Blood also bathes microtubules or coils filled with temperature-controlled water that are usually embedded in the membrane lung. This means that ECMO tightly controls the patient's temperature. So, how do we remove CO2? Well, the sweep gas flow rate is analogous to minute ventilation of the native lung. With a high sweep flow rate, a steep diffusion gradient is maintained for CO2 to travel from the blood across the semipermeable membrane into the microtubule lumen. So, to lower the arterial CO2, increase the sweep gas flow rate. The sweep gas flow rate doesn't affect oxygenation unless the sweep gas is turned off. But as long as the sweep gas is on, the membrane lung will fully saturate hemoglobin at most sweep gas flow rates, and additional changes in sweep gas flow rate will have minimal effect on oxygenation. What is the goal SpO2 on VV ECMO? Adequate tissue oxygenation is dependent upon the ratio of delivery to consumption. Delivery of oxygen depends on oxygen saturation, hemoglobin concentration, and cardiac output. If this ratio is inadequate, the mixed venous saturation will be low and tissue hypoxia will occur, which results in end organ dysfunction and an elevated lactate. As with standard ARDS management, the goal arterial oxygen saturation is greater than 88% with hemoglobin greater than 7. However, sometimes, despite optimization of ECMO support, we need to accept a lower oxygen saturation goal on ECMO in order to facilitate de-escalation of ventilator settings to avoid ventilator-induced lung injury. Close monitoring of end organ function is essential to determine if the SpO2 and hemoglobin goals are high enough. Now let's talk about how to troubleshoot hypoxemia. The membrane lung sends fully oxygenated blood, S post O2, to be entrained into the heart. Some central venous blood, SCVO2, is also entrained into the heart. ECMO thus increases the oxygen saturation of the blood being entrained into the heart, through the poorly functioning lungs where some gas exchange may occur, and then into the aorta to determine the SaO2. Essentially, now you have two lungs in series with the membrane lung performing gas exchange before the native lung. Now the composition of the blood entering the heart depends on the ratio of ECMO blood flow to native cardiac output. The figure on the left depicts high ECMO blood flow with a large red arrow, with a small amount of residual central venous blood, the small blue arrows, entrained into the heart, resulting in a well-oxygenated pulmonary artery. The ECMO blood flow is decreased in the figure on the right, resulting in larger amounts of deoxygenated central venous blood to be entrained into the heart, as dictated by the cardiac output, which leads to a lower oxygen saturation of the pulmonary artery. Ideally, you want to achieve an ECMO blood flow of at least 60% of the cardiac output to achieve a reasonable arterial oxygen saturation. A patient's cardiac output is dynamic throughout an ECMO run, and the ECMO blood flow needs to be adjusted accordingly. In summary, the primary way to increase the SpO2 on VV ECMO is to increase the ECMO blood flow rate. So how high can you increase the flow? You can increase the flow until you run into excessive circuit pressures that lead to high-level hemolysis. As you increase the flow, the negative drainage pressures and positive return pressures will become more extreme. Each circuit is unique, and there is no standard pressure limit at which hemolysis occurs. The second important limitation to increases in blood flow is the occurrence of pathologic recirculation. So when is pathologic recirculation happening? The figure on the left shows normal ECMO blood flow where most of the blood from the return cannula is entrained into the heart. The figure on the right demonstrates recirculation where a significant portion of blood from the return cannula feeds into the drainage cannula instead of being entrained into the native heart. Normally, the drainage tubing is dark red and the return tubing is bright red. When significant recirculation occurs, both tubes are bright red. Recirculation is increased with higher flow and cannulas that are closer together. As the speed is increased to increase ECMO blood flow, the drainage pressure becomes more negative, leading to more blood from the return cannula being sucked into the drainage cannula. This means that initially the SpO2 will rise and then will fall as the recirculation fraction increases. The saturation of blood entering the pump, the S pre-O2, or venous drainage oxygen saturation, will continue to rise. You want to choose the blood flow yielding the maximum SpO2. Pathologic recirculation is occurring with increased flow to the right of this black dotted line where S pre-O2 is rising and the patient is becoming hypoxemic. Additionally, when cannulas are closer together, recirculation will increase. So, in summary, if you have pathologic recirculation, first decrease the speed, then check your cannula position. How do I detect circuit gas exchange failure? There are two types of failure: sweep gas flow interruption and membrane lung failure. Sweep gas flow interruption, such as disconnection of the tubing or an empty oxygen tank, means the membrane lung is apneic and you are essentially off ECMO support. Membrane lung failure can be due to gas phase failure in the lumens of the microtubules or blood phase failure where clot and fibrin build up on the microtubules, both inhibiting gas exchange. Membrane lung failure usually occurs slowly over days, and function of the membrane lung is monitored with periodic pre- and post-membrane blood gases to detect impending failure prior to the loss of post-membrane oxygenation. Blood phase failure often correlates with clots visible on the membrane lung window and an increasing delta P. This is the pressure drop measured across the membrane lung, which reflects resistance. An increasing trend in the delta P should trigger concern, in particular if it doubles in value. As we previously saw, normally there is color differentiation between the tubing, with one tube being dark and the other bright. Circuit gas exchange failure resulting in no oxygenation post-membrane will lead to both tubes being dark. How should I manage the ventilator while on VV ECMO? Current evidence is limited, but a few general principles are recommended by experienced high-volume ECMO centers. The PEEP is generally moderate, around 10 to 14, and the driving pressure is usually 10 to 14 to maintain a total pressure less than 25. The FiO2 is ideally less than 50%, and the respiratory rate should remain low, around 10. In general, ECMO allows for de-escalation of ventilator settings to avoid further ventilator-induced lung injury, so-called lung rest, while awaiting recovery. This is why the pressures, rate, and FiO2 goals are ideally lower than usual while on ECMO. It is not uncommon for a chest radiograph to white out while on ECMO, and thus tidal volumes will be very small at these ultra-lung protective settings. In summary, increase the sweep gas flow rate to remove more CO2. A common SpO2 goal is greater than 88%, but lower goals may be acceptable if ECMO support has otherwise been maximized. If the patient is hypoxemic, first try increasing the ECMO blood flow and address any pathologic recirculation. Monitor for membrane lung failure, and avoid further ventilator-induced lung injury by allowing lung rest with de-escalated ventilator settings and await pulmonary recovery.